following this, we do not have any extra meetings or journal club this morning. CME color for the day, which I will post in a second on the group chat here, will be gray. And without further ado, well, I would like to just make one quick comment. Obviously, everybody sees the national statistics with COVID. We're clearly not ready to re-enter into in-person meetings with the current trends, but just like to remind everybody to be thoughtful about your exposures. The Atrium report has had a lot of out-of-hospital exposures being issues with employees as opposed to actual patient exposure or in-hospital exposure. So let's all just be thoughtful about what we do and be careful. So again, CME color of the day is gray. And for our first talk this morning, we have Dr. Jolissaint, who is going to talk to us about midshaft clavicle fractures. Joseph, take it away.
Awesome. Thank you so much, Dr. Pat. As Dr. Pat mentioned, my name is Josef Jolissaint. I'm one of the PGY2s here. And my topic this morning will be midshaft clavicle fractures, evolution of management. So I'd like to start with a case. Dr. A.H. is a 50-year-old surgeon who was riding a scooter when he fell and sustained a left completely displaced midshaft clavicle fracture. On a clinical examination, his skin was not compromised and there was no neurovascular injury. So throughout this talk, I'd like you to consider the following. What factors do you consider when evaluating this patient? What discussion would you have with this patient? And ultimately, what would you recommend, operative or non-operative management? Clavicle fractures account for 2.6 to 4% of all adult fractures and 44% of fractures within the shoulder girdle. They most often occur in young active males under the age of 30, and 75 to 80% of clavicle fractures occur in the middle third. In the interest of time, my topic this morning will focus on these middle third or midshaft clavicle fractures, while realizing there are proximal and distal fractures with separate considerations for management. The mechanism of injury is typically a fall on either the point of the shoulder or onto an outstretched arm, causing an axial load through the clavicle. Physical exam of these patients often reveals noticeable deformity and should focus on a detailed neurovascular exam as well as close evaluation of the skin. When evaluating clavicle fractures, in addition to a thorough physical exam, it's important to obtain appropriate radiographs. A simple AP radiograph is not sufficient to fully evaluate the fracture. Radiographs with 15 degrees of cephalic tilt, also known as the Zenka view, is helpful in determining a superior and inferior displacement, while radiographs with caudal tilt are helpful in determining anterior and posterior displacement. Dr. Neer has a classification of midshaft clavicle fractures with two broad categories, one being less than 100% displaced and the other greater than or equal to 100% displacement. There's also an AO classification based on fracture pattern characteristics, which can be seen here on the table to the right. However, most often we speak of midshaft clavicle fractures in completely displaced or not. So once the diagnosis is confirmed, the most important consideration is management. Questions to consider are, what are the results with non-operative treatment? What's the risk of non-union? Can it be predicted? Should they be fixed at all? And if so, when? And in whom should they be fixed? In order to answer these questions, I will go through the evolution of our understanding of these fractures and highlight high-level literature which has been published throughout the years. So clavicle fractures have been recognized and treated for centuries. When managing these injuries, Hippocrates wrote, "But in a little time, the patients having no pain, nor finding any impediment to their walking or eating become negligent, and in the meantime, the callus is quickly formed." Following in the footsteps of the father of medicine, non-operative management of clavicle fractures became dogmatic and was heavily supported in the literature. Notably, all of the literature from the 1950s to the 1990s was surgeon-based or radiographic-based rather than patient-oriented. Watson and Jones in 1955, Bowler in 1956, and Neer in 1960 all supported non-operative management of all clavicle fractures. Clinical Orthopedics and Related Research in 1968 had two successive chapters by Rowe and Neer describing non-operative management of both midshaft and lateral clavicle fractures. And several pictures from those chapters can be seen there on the right. A quote from that edition of Core reads, "Operative treatment is not only meddlesome, but can increase the non-union rate significantly." It's important to understand that much of this thinking came from the original works of Neer and Rowe, when operative techniques were variable and not standardized or refined. Building on their original work of Neer and Rowe et al. In the 1960s, several studies published throughout the 1970s, 80s, and 90s demonstrated groupthink and supported this dogma. In 1977, Blomer et al. Published a study of 151 patients with clavicle fractures and found that neither axial angulation nor shortening caused shoulder dysfunction. In 1993, Peterson et al. Published a study of 99 patients with clavicle fractures and found that 90% had no pain at follow-up, and shortening and displacement were not risk factors for pain. In 1997, Nordquist et al. Published a 5-year follow-up of midshaft clavicle fractures and assessed outcome relative to displacement and combination. They concluded that clavicles with initially displaced fractures were shorter and more frequently malunited or non-united. However, mobility, strength, and the functional constant score were similar. In 1999, Arauco et al. Published similar findings after evaluating 42 patients with greater than or equal to 15 millimeters of shortening at least 3 months after injury. So these studies led to the idea that all midshaft clavicle fractures, displaced or not, should be treated non-operatively because, according to available literature, they do fine. They have virtually no functional limitations and they all heal. Well, is it all or is it some? Some within the orthopedic community still felt strongly that clavicle fractures don't all do well with non-operative management, and that further investigation was warranted, and those questions and investigations led us to where we are today. Clavicle fractures are no exception to the rule of there being no absolutes in medicine. The existing literature is relatively clear. All midshaft clavicle fractures do not do well with non-operative management. In 1997, Hill et al. Were the first to use patient-oriented assessments rather than surgeon or radiographic measurements, which are important considerations to evaluate outcomes after non-operative treatment of displaced clavicle fractures. In an article titled "Closed Treatment of Displaced Middle Third Fractures of the Clavicle Gives Poor Results," they found that 31% of patients described unsatisfactory outcome after non-operative care of displaced clavicle fractures. They postulated that this may be explained by significant residual deficits following the conservative treatment of these fractures, which weren't previously identified using those surgeon or radiographic measurements. Additionally, they had a 15% incidence of non-union in their study and found that shortening of greater than or equal to 2 centimeters was associated with non-union. McKee et al. Sought to evaluate a group of 105 polytrauma patients with clavicle fractures and published his findings in the Journal of Trauma and Acute Care Surgery in 1999. He found that the mean DASH score in this population was 32, indicating major residual impairment. Nowak et al. Conducted a prospective study with at least 9 years of follow-up, examining the late sequelae in 208 adult patients with clavicle fractures, and found that of those 208 patients, 96 or 46% still had sequelae. They found that the strongest predictor for sequelae was no bony contact, comminuted fractures with transverse fragments, and age. They concluded that patients with predictive risk factors, such as fractures with no bony contact or displacement, especially if comminuted, and also elderly patients with fractures, should be considered for more active treatment options. Seeing that non-union is a significant issue and is often what drives poor outcomes, Robinson and colleagues sought to further delineate and describe which of midshaft fractures go on to uneventful union and which ones go on to non-union. They published their findings with a predictive model to guide treatment in certain populations in JBJS in 2004. Over a 51-month period, they performed a prospective observational cohort study of a consecutive series of 868 patients with non-operatively treated clavicle fractures. They were evaluated clinically and radiographically at 6, 12, and 24 weeks after the injury. They found an overall 4.5% risk of non-union. However, they found a significantly increased incidence in certain situations, including lack of bony contact, advancing age, female gender, and combination. As can be seen here in Robinson's published results, where gender, age, fracture displacement, and comminutions were noted to be important considerations, patients who met several of those criteria had a dramatically increased risk of non-union. A 65-year-old female with a clavicle fracture that was displaced and comminuted had an almost 50% chance of going on to non-union in their patient cohort. McKee et al. Used more sophisticated outcome measurements in an additional study, including the constant and DASH scores, as well as muscle strength testing. They published their findings in JBJS in 2006 with a paper titled "Deficits Following Non-Operative Treatment of Displaced Midshaft Clavicle Fractures." At a mean of 55 months, they found residual deficits in shoulder strength, especially endurance strength, compared to the contralateral arm, in a cohort of 107 non-operatively treated displaced midshaft clavicle fractures. Clavicle shortening was associated with a trend toward decreased abduction strength, and shortening of greater than or equal to 2 centimeters was associated with a trend toward greater patient dissatisfaction. So based upon their findings, McKee et al. Postulated that while traditionally good results with minimal functional deficits have been reported following non-operative treatment of clavicle fractures, surgeon-based methods of evaluation may be insensitive to loss of muscle strength. And the residual deficits in shoulder strength and endurance in this patient population may be related to the significant level of dysfunction detected by those patient-based outcome measures. The work done by McKee, Nowak, and Robinson established that non-operative treatment may lead to unsatisfactory outcomes. However, no randomized controlled trials had yet been performed to investigate if operative treatment was superior. Well, in 2007, McKee et al. And the Canadian Orthopedic Trauma Society conducted a multi-center randomized controlled trial consisting of 132 patients. Those 132 patients were randomized to operative treatment with plate fixation or non-operative treatment via sealed envelope. They found that operative treatment resulted in statistically significant improvements in every category assessed: constant shoulder scores, dash scores at all time points, time to union, rate of non-union, symptomatic malunion, and overall satisfaction. Complications, as defined as necessitating further medical treatment or operation, were actually greater in the non-operative group. However, operative complications were not benign. Most complications in the operative group were hardware related. 5 patients had local irritation and or prominence of the hardware, 3 had a wound infection, and 1 had mechanical failure. Thereafter, several randomized controlled trials were performed and published. McKee et al. Published a systematic review of these randomized controlled trials in JBJS British in 2012. Studies were included in that review if they were randomized prospective trials of operative versus non-operative treatment of acute, completely displaced midshaft clavicle fractures. And he noted that operative treatment resulted in, again, statistically better rate of union, better rate of non-union, rate of malunion, and an earlier return to functional activities. In an article published in JBJS in 2013 titled Risk Factors for Non-Union After Non-Operative Treatment of Displaced Midshaft Fractures of the Clavicle, Murray et al. Sought to further delineate risk factors for non-union and provide valuable information for the management of clavicle fractures. 941 diaphyseal clavicle fractures were followed to union or non-union. Demographic, injury, and radiograph characteristics associated with non-union were determined via bivariate and multivariate analysis. In their study, 125 or 13.3% of the fractures had clinical and radiographic evidence of non-union. And the greatest odds ratio after multivariate analysis were smoking, combination, and fracture displacement. Interestingly, if all displaced midshaft fractures were managed operatively in this study, 7.5 procedures would need to be undertaken to prevent a single non-union. However, if only fractures with a predicted probability of greater than or equal to 40% were managed operatively, the number of patients managed operatively to prevent a single non-union would fall to 1.7. This paper helped introduce the idea of appropriate targeted patient selection, as well as patient counseling when managing clavicle fractures. It provided statistical modeling to predict non-union based on known risk factors, and also identified smoking cessation as an integral part of treatment. Due to the increasing trend toward treating midshaft clavicle fractures with plate fixation, Robinson et al. Performed a multi-center randomized controlled trial of 200 patients, comparing open reduction and plate fixation of displaced midshaft clavicle fractures with non-operative management. They published their findings in JBJS in 2013. They found that the rate of non-union was significantly reduced after open reduction and plate fixation as compared with non-operative treatment, and found that group allocation to non-operative treatment was independently predictive of the development of non-union. Overall, they found that dash and constant scores were significantly better after open reduction and plate fixation than after non-operative treatment at the time of the 1-year follow-up. Woltz et al. Recently conducted another multi-center randomized controlled trial comparing open reduction and plate fixation to non-operative treatment in displaced midshaft clavicle fractures. Their primary outcome was non-union at 1 year, and they evaluated several additional secondary outcomes at 6 weeks, 3 months, and 1 year following the trauma. They found that plate fixation reliably and significantly decreased the rate of non-union. They additionally found that the rate of secondary operations was 27.4% in the operatively treated group, compared with 17.1% in the non-operatively treated group. However, this result did not achieve statistical significance. So, based on reviewed literature, the evolving indications for considering surgical management include the aforementioned risk factors, which are known to increase the risk of non-union and poor outcomes, including lack of bony contact or greater than centimeters of shortening, combination, Z deformity, as well as patient-specific factors. However, the question remains, does delay matter? Can we just treat all midshaft clavicle fractures non-operatively at first and fix those that go into non-union, or with symptomatic malunion later? Well, Potter, McKee et al. Sought to answer this question. They identified 30 patients who sustained displaced midshaft clavicle fractures, 15 of which underwent immediate compression plating at a mean of 0.6 months, and 15 of which underwent delayed fixation and grafting at a mean of 63 months. They found no significant differences between acute fixation and delayed reconstruction groups with regard to strength of shoulder flexion and strength and endurance of abduction, external rotation, or internal rotation. Dash scores were improved in the acute group, however, that did not reach statistical significance. However, constant scores in the acute group were superior, and shoulder flexion muscle endurance was significantly decreased in the delayed group. They concluded that late reconstruction of non-union and malunion after displaced midshaft fractures of the clavicle is reliable and reproducible. It results in restoration of objective muscle strength similar to that seen with immediate fixation. However, results are not the same as treating acutely. There are decreases in endurance strength and outcome compared with acute fracture repair. So, at a busy level 1 trauma center with over 115,000 patients being seen in the ED annually, frequently complex and life-threatening pathology and limited OR availability, delayed management may be the appropriate option. However, if delayed management is chosen, it's prudent to know the consequences of non-operative management. Schottel et al. In 2015 published a very unique study on the effect of quality of life of a long bone non-union. Time trade-off scores were obtained for 832 non-union cases upon initial clinical evaluation. Health status utilities were calculated with the use of the time trade-off and were based upon the percentage of each patient's life that he or she was willing to trade to obtain perfect health using a hypothetical 10-year life expectancy scenario. Patients with clavicle non-union in this study were willing to trade 41% of his or her hypothetical 10 years of remaining life. This was worse than AIDS, stroke with a moderate deficit, myocardial infarction, and was on par with an end-stage renal disease pre-renal transplant. This study shows that there is a price to pay with non-operative management, specifically if non-union occurs. Patients should be aware of the risks and benefits of both operative and non-operative management so that they can come to an informed, shared decision with their treating physician. When having an informed discussion with the patient and deciding between operative and non-operative management with shared decision-making, it's also important to think specifically about the patient population we're treating, rather than just simply treating the disease pathology. A study performed by Dr. Hsu with the Skeletal Trauma Research Consortium on a military population known to be heavy shoulder bearers found that for the majority of active duty personnel, plate fixation resulted in rapid healing, return to military-specific tasks, and overall satisfaction. A randomized controlled trial by Malian et al. Published in JSES regarding outcomes of surgical treatment in a workers' compensation population showed that surgical treatment with ORIF of displaced middle third clavicle fractures achieved good and excellent functional results, shorter time to complete return to work, earlier bone union, and fewer cases of non-union. A paper published in AJSM by Dr. Connor in 2010 looked specifically at NFL players with a completely displaced middle third clavicle fracture. Nearly 50% of those players were treated successfully with acute surgical fixation without sequelae and healed at an average of 8.8 weeks. Half of those players treated surgically were able to return to play during the same season. In addition, 4 of the 7 players initially treated non-operatively for those completely displaced middle third clavicle fractures refractured their clavicle within a 1-year period. Those 4 players missed an average of 1.5 seasons because of their clavicle injury and subsequent clinical course. Well, when the decision is made to proceed with surgery for displaced midshaft clavicle fractures, there are numerous methods of treatment. The vast majority of surgeons utilize open reduction and plate fixation. However, some surgeons advocate strongly for intramedullary nail fixation, and the reality is that equivocal results have been published with both. Several randomized controlled trials have been performed and ultimately show that, in terms of functional outcome, the result is similar. There are no differences in constant or dash scores. However, there are advantages and disadvantages to both. Plate fixation provides rigid fixation, allowing early weight bearing and range of motion, and also provides a quicker recovery. Intramedullary nail is more aesthetically pleasing and requires less soft tissue dissection. However, 100% of those require a second surgery for removal, and in the interim, many patients have symptomatic hardware. So back to our case. When discussing treatment options with Dr. A.H., a 50-year-old surgeon with a displaced midshaft clavicle fracture, reliable return to work was an important factor, along with the risks and benefits of both non-operative and operative management. Understanding those risks and benefits of both operative and non-operative management, the risk of non-union, he elected to undergo operative management, and he was back to operating himself 7 days later. In summary, Midshaft clavicle fractures account for approximately 80% of all clavicle fractures and have traditionally been treated non-operatively, even when significantly displaced. However, more recent studies have shown non-union rates of up to 21% in displaced midshaft clavicle fractures and unsatisfactory patient-oriented outcomes in up to 31%. Patients with a clavicle non-union have been shown in the evidence to have an unacceptably low health utility score, less than that of AIDS, stroke of the moderate deficit, hepatitis C, type 2 diabetes, DNR. The preponderance of evidence from level 1 prospective and or randomized trials indicate that for carefully selected patients, primary operative fixation of displaced clavicle fractures, meaning 100% displaced, greater than 2 centimeters shortened, results in reliably superior outcomes, faster return to work, and overall satisfaction. If operative management is pursued, plate fixation results in quicker recovery and comparable outcomes to intramedullary now. I'd like to give a huge thank you to Dr. Connor, Dr. Hammond, and Dr. Shu for their assistance in making this presentation. And I'd also like to give a shout out to Dr. Brandt, Dr. Lee, and Dr. Seacrest.
Excellent. Thank you, Joseph. Great talk and review of a topic which has historically divided parties. Not quite on par with religion and politics, but certainly lots of opinions out there about clavicle fractures. I see Dr. Mormon's face on there. T, you want to start the conversation? And Joseph, maybe unshare your screen, and if we could ask everybody to turn their cameras on so we could see everybody this morning.
Well, Joseph, fantastic review, and I think you covered all the major bases on it. One of the things about the intramedullary pins, we started doing these influenced by Carl Basmania, who came from Fort Bragg, and they have this, I think it's a little bit prehistoric concept that hardware has to come out before they can jump, for the paratroopers. So that was one of the things that led Carl to really want to do the intramedullary pins, because, as you pointed out, they all have to come out. The coming out's not a big deal, though. It's a little portal laterally. And so, 100% of them need a second operation. Actually, it's not 100%. I had some people that talked me into leaving them in, and some people do okay if they don't get that bursa laterally. But the plates probably are the standard of care, just related to the newly contoured plates and the reliability of that operation. And there are some problems with the pins. Pat Connor, who you already quoted once, and D'Alessandro et al. Here in Charlotte, published a paper on the intramedullary pins that was published earlier this year in JSOA, and they showed 100% union and good results with the pins too. So I don't think there's much controversy about whether a displaced and shortened clavicle needs to be fixed, particularly in a young patient, but I think there is still controversy about the best way to fix it. For now, I think the board answer is going to be plate fixation, but the pin has a role as well. A great review on the topic.
Thank you, sir.
Hey, Joseph, it's Natty. That was a really nice review of the literature. I don't have a lot to add. The controversy is really the patient scenario. And if you have a multiply injured patient, clavicle probably should be prioritized when discussing treatment options and order of treatments for other injuries. But for the isolated clavicle fracture, I think you showed well that for the displaced comminuted fractures, midshaft clavicle fractures, the strong consideration should be given to plate fixation in those patients. And those patients want to know two things. They want to know how well the bone's going to unite with both treatment options, and they want to know how quickly they can get back to their normal life. And if you answer those two questions for them based on the evidence, the conversation will quickly go to surgical management based on all the literature that's been published over the last 15 years. But great job with the talk, and I appreciated the evolution of the research and science behind learning more about clavicle fractures over the last 3 decades.
Thanks.
I see Dr. Harmer, our new trauma partner up at Northeast on the line. Luke has the distinction of having done a trauma fellowship and a shoulder and elbow fellowship, so he can maybe give us a cross-sectional view or impression of this topic. Luke, any thoughts?
No, I think everything's been summed up well. I think patient factors are the main thing. So like so many things in upper extremity fracture surgery, there's controversy about exactly who could benefit from surgery. In the right patient population, fixation is absolutely the right thing, as Dr. Hammond said. but choosing the right patient and perhaps excluding some patients when they have risk factors, diabetes, things like that. Any of us who've treated these operatively have, come across infections and have, had some complications. So choosing the right fracture, in some ways similar to proximal humerus fractures, I think is where the future of clavicle fracture fixation is going.
Any other comments?
One other thing to consider that I don't think you mentioned, Joseph, with all the literature that's out there and statistically significant differences in outcomes in various compared groups. I think it's important also to consider minimal clinically important differences, because there are certainly some studies that have shown statistically significant differences in outcomes of measured outcomes of clavicle fractures without necessarily minimal clinically important differences. And another consideration to conclude, or to consider, is another thing to consider is whether or not or the source of worse outcomes. So one of the things I'll tell patients often is, quoting risks for non-unions, and that being a common source for bad outcomes. But if their clavicle fracture heals, that doesn't necessarily mean their outcome is going to fit into the average outcome for patients who have non-unions. I think those are considerations.
Thank you.
Sorry, actually, the other thing too is I thought it was interesting that the ABOS web-based longitudinal assessment list of articles for continuing medical education included, of all of the literature on clavicle fractures, included a study that randomized controlled trial whose outcomes were similar clinical outcomes in patients who got surgery versus not surgery, with a major difference being more higher risk for return to the OR in patients who got surgery. I don't think they're necessarily advocating for non-operative treatment, but I just thought it was interesting that was the article they picked, and maybe subtly suggests that they think we're operating on too many clavicle fractures and should be careful about patient selection, as you mentioned.
Along those lines, Larry, I'd be interested in people's opinion. What is this? We talk about Tommy John surgery and people wanting to come in and request it to, improve their pitching, and how do we deal with that in little league players? Well, what about the patient who doesn't have a significantly displaced fracture and has one that in your heart is going to heal very well with non-operative treatment, but they're just going to be out for a little while, and they basically come in demanding surgery? Are people, treating this like an elective, procedure and saying, sure, we can fix it, no problem? Or is anybody actively counseling against fixation in these minimally displaced ones?
I've only had that happen once, where a patient told me they wanted surgery because they heard that they were supposed to have it in a minimally displaced clavicle fracture. And I just told them that they could seek a second opinion, but that I didn't think the benefits outweighed the risks. And I've heard kind of as a joke, people refer to surgeries like that as being a skeletal cosmetologist.
Anyone else have experience with that situation?
I would agree with Larry that that's a pretty uncommon scenario. Usually the patients I'm seeing, it's high energy injuries from cycling, or other physicians or whatever have had some significant fall. I rarely see a minimally displaced one. It's usually 100% displaced, Z fracture deformity, some shortening, and I do exactly what Natty said, and as Joseph presented, and given the options, I don't tell them what to do or not to do, but it's pretty hard for me, even at just presenting that data, to talk them out of having it fixed, just because they don't want the uncertainty and potential delay of trying to treat it non-operatively. They're active people and they want to get back as predictably as possible, as quickly as possible. And I basically don't even have them wear a sling for more than a day after the surgery. They can pretty much move and use their arm right away and predictably get back to their sports, within a couple of months even.
Great.
One interesting thing for patient education that I learned in a case series, we were playing Louisville when I was the team doc at Duke, and we had Duke players on successive plays fracture their clavicle. The first was a wide receiver who had a perched fracture that was really a little bit angulated, but completely non-displaced. And we treated him non-operatively. The second one was our punter, who had a badly comminuted and shortened fracture that we plated the next day. And the one that we plated felt immediately relief of his pain, and he was great. The other guy was wondering for the next 3 or 4 weeks why the hell we didn't operate on him, because he hurt like hell. So just by way of patient expectation, the ones that are treated non-operatively, they're pretty sore for 2 or 3 weeks until the thing starts to get sticky. So just one thing by way of patient expectation.